We will be moving on to this next session on diabetes on chronic kidney disease. One of the most important microvascular complications of diabetes. We will dwell in detail about diabetes and chronic kidney disease. So this module we have divided into 3 parts. The first part that we are going to see now will be on diagnosis. Then the second part we will look into the management aspects of diabetic kidney disease, and the third part will be on management of diabetes in chronic kidney disease patients. So that's how our flow of these 3 modules are going to be. So with the advent of all newer investigations, treatment and various modalities and therapeutics, everything available, this one particular study which is published in Lancet, which looked into the global burden of all diseases. So if you see here, like the global burden of all diseases is quantified in by this acronym DALY. DALY means Disability Adjusted Life in Years. So this is the data as on 1990. So what does this disability adjusted life in years is all about is, generally we talk any disease about the mortality aspect or on the morbidity aspect. So DALY is one thing like where both mortality as well as morbidity of the disease is taken into account. So if you see, like you can see even the headache. So for headache there won't be much mortality, but the morbidity, the suffering will be more. So if you see depressive disorder, same thing. So if you see the iron deficiency, again the same thing. So it looks into not only the diseases in the perspective of mortality, it looks at the diseases in the perspective of morbidity also. So that is what DALY looks into. So way back in 1990, the chronic kidney disease was in the rank of 29 with a DALY, adjusted DALY of about 0.8. So whatever the DALY is, with the advent of all these things, the current data in 2019 shows that the chronic kidney disease has a whooping up. So it has moved from 29 to 18. And the DALY has also, it is doubled. Exactly, it has become double. So with all the advent that has happened, we are not able to control this burden of chronic kidney disease, of which diabetes contributes a major part. So this is what the epidemiology of diabetes and chronic kidney disease has become a bigger burden on the human community as such. Having said that, diabetic kidney disease is a complex and heterogeneous disease with numerous overlapping etiologic pathways. So one thing that is important as we need to know as a clinician is, diabetes produces lots of advanced glycation end products and reactive oxygen species. So it boggles down to this. So the production of this advanced glycation end product and reactive oxygen species are important for almost all the microvascular complication of diabetes, be it retinopathy, be it neuropathy. It all is because of this glycation end product and the reactive oxygen species which is produced. So these glycation end products and the reactive oxygen species, they activate the intracellular signaling for pro-inflammatory and pro-fibrotic gene expression with the production of host of mediators for cellular injury. So lots of factors are brought in for the cascade of events that happens after that, but it all starts with this glycation end products and the reactive oxygen species, which we need to remember very clearly. So it is not only about these glycation end products and the reactive oxygen species. There is a contribution from hyperinsulinemia and insulin resistance also. That is the reason when we see the histopathological subtypes between type 1 and type 2, there are lots of variations. So what brings these variations on the histopathology between type 1 and type 2 is based on the hyperinsulinemia and the insulin resistance, which contribute to the pathogenesis of diabetes. So this is also come into play. So on pathophysiology, what we need to remember clearly is the glycation end products and the reactive oxygen species brings in the host of factors which is responsible for the cascade of events in diabetic nephropathy. So the diabetic milieu per se stimulates or activates the renin-angiotensin-aldosterone system. So we'll just briefly see in a while how it activates the renin-angiotensin-aldosterone system. So the activation of renin-angiotensin-aldosterone pathway causes, it triggers the kidney hypertrophy. It increases the renal plasma flow. It increases the filtration fraction also. So very, very important that it stimulates the kidney hypertrophy also, because this is very, very important, that the initial kidney, especially in diabetics, becomes slightly enlarged. So that is because of the activation of the renin, angiotensin, aldosterone. And this kidney hypertrophy is the one which is essential for which contributes to the glomerular hyperfiltration. So we will see in a short while what glomerular hyperfiltration is all about. So it creates, first thing, a kidney hypertrophy is being triggered, and there is an increase in the renal plasma flow, and the filtration fraction of the Bowman's capsule is also increased. So this causes abnormally elevated glomerular filtration rate. So the first thing that we need to remember is, when this diabetic milieu activates, because of the activation of the RAS system, two things are important. One is the kidney hypertrophy which is happening, and the second thing is the abnormally elevated glomerular filtration rate. So generally when we see the kidney changes, the chronic kidney disease is associated with the decline in the glomerular filtration rate. We will see in detail about the glomerular filtration rate. But what is important is, diabetes in the first stages, in the initial stages, it causes an abnormally elevated glomerular filtration rate. So in the early stages of diabetes, both, we will look into what this two concepts are meaning slightly later. The whole kidney GFR as well as the single nephron GFR are increased. So just remember only one small concepts about these things. What is meant by a whole kidney GFR and single nephron GFR? So the whole kidney GFR is the summation of all the single nephron GFR which is present in the kidney. So in both the kidneys, so it is the product of the single nephron GFR is whole kidney GFR. In what way both these concepts or both this terminology differ is, the single nephron GFR is unaltered by the age of the patient, whereas the whole kidney GFR slightly declines as the patient age increases. So with the advance of age, the GFR declines with the whole kidney GFR, whereas in single nephron GFR, it remains the same. So understand this concept. We will see how diabetes comes into play with both these concepts. So these states, both the whole kidney GFR as well as the single nephron GFR, both are increased in diabetes, and it is referred as the glomerular hyperfiltration rate, where there is an increase in the glomerular filtration rate which happens with this in the early stage of diabetes.